Thanks for joining us today for our grand rounds. We have our faculty development residents giving us presentation. So we have Dr. Cornelius going first, and he's going to talk to us about emergency contraception. And then Dr. Garcia will follow up with monkeypox with OB considerations. So I'll hand it over. So if you have questions, wait until the end of Dr. Cornelius' presentation and you can ask questions, and then we do the same after Dr. Garcia's presentation.
Awesome. Thank you so much, Dr. Gosa? Dr. Gosa. Well, I'm Steve. I'm one of the third-year residents over at Fort Belvoir Community Hospital, and my peers and I had the fortune of being selected for this faculty development rotation. I had a blast. I don't know. I thought it was just a really fun time. For me, I kind of was interested in teaching and scholarship earlier. Even when I was on a deployment, I was working with a whole bunch of corpsmen, teaching them, and just realizing how fulfilled I was improving their medical knowledge. So then I get here, and it's just been such a treat with these new medical students who know nothing about the physical exam and medical interviewing, and just starting from square one. Just have been a truly fulfilling process, and so I am very grateful to everyone who's been helping us with this. Looks like it just dims. Okay. Anyway, so I'm going to talk to you at all about emergency contraception in the post-Roe v. Wade period, with absolutely no political discourse involved, just kind of stating the facts. I realize this is a slightly more sensitive topic, but I think it's also relatively appropriate at this time, given the new introduction of the post-Roe v. Wade. So going with that, we'll look through some objectives. The first thing I wanted to talk about is actually the concept of pregnancy, and essentially whether patients and providers are comfortable administering emergency contraception given the definition of pregnancy that I'm going to give. I'm going to talk a little bit about the most commonly used forms of contraception, and then follow up with the impact of post-Roe v. Wade on the military health system itself. And then finally, just to give this talk a little military medical flair, I'm going to talk about different alternative options that can be utilized in austere military environments. So let's get started with pregnancy, which is something we've all know really quite a lot about, but there's absolutely some debate with regard to when pregnancy begins. A lot of people think pregnancy begins the moment that sperm meets up with the egg, it fertilizes, you have a diploid zygote, 46 chromosomes, great. That's when pregnancy begins. However, when that happens, we don't actually have any evidence of the pregnancy. There are no hormonal implications for the patient, no breast tenderness. Obviously, no loss of period. There's mood swings associated with pregnancy. None of that happens right when the egg meets the sperm. We also don't know that the patient's pregnant at that point because the implantation itself is what causes the increase in the HCG to give us a positive pregnancy test. Okay, so then there's another group of people that are saying, okay, well, pregnancy doesn't start right at fertilization. It actually starts at implantation, because at that point we are having systemic responses for the patient themselves, and we have the chemical increase in the HCG indicating that there actually is a pregnancy. Again, this is a really heavily debated topic. A lot of people think one way and think another way. And for the purpose of today's discussion, I'm actually defining the pregnancy as starting at implantation of the fertilized egg and not when the egg and sperm meet. With that definition in mind, emergency contraception does not act as an abortive agent. What it does do is it prevents a pregnancy after unprotected sex. In other words, emergency contraception does not work if you are already pregnant. Okay, so now let's talk a little bit about the different forms of birth control for emergency contraception themselves. We'll start off with my absolute favorite, Paragard. I hate putting these in. But it works really, really well with regard to emergency contraception. So copper IUD, Paragard, it works within the first 5 days of unprotected sex. The different mechanisms of how it works, it interferes with sperm transport, fertilization, it prevents implantation by creating an inhospitable environment for the zygote. And it works really well. It's about as good as emergency contraception as you possibly could have, reduces the chance of pregnancy greater than 99%. And the other thing that's nice about this form of emergency contraception is not affected by the patient's BMI. And then, of course, one of the benefits, as long as the patient isn't, yelling and getting angry at you for having bleeding and cramping for the next 12 years, it can be used for long-acting reversible contraception for that entire duration of time. So if we're working from highest efficacy to lower efficacy, the second best one that we know of, it's an oral pill, is Ella. So the window of treatment also is within 5 days. Recommended that you take this medication as soon as possible after unprotected sex. This medication, when administered prior to follicular rupture, prevents ovulation. It also prevents progestin from binding the progesterone receptor and may alter the endometrium, thus impairing implantation. I keep hitting on this, and I have this underlined for a reason. We'll get back to that in a little bit. Efficacy, not quite as good as the Paragard IUD, but it's quoted as having medium to high efficacy. There are a lot of different studies, different numbers on how good this is. The best one that I could find from a meta review back in 2020 said it was actually 98 to 99%, so pretty darn good. The efficacy is slightly reduced if the BMI is greater than 35. Okay, so now we'll talk about the one that everyone knows about, but probably has the lowest efficacy. So this is our Plan B levonorgestrel. It works best, or we administer it within the first 72 hours of unprotected sex. If it is not administered in that time frame, we are concerned about it not working at all. This medication, it thickens cervical mucus, leading, and it also leads to reduced secretion of FSH and LH. It alters the endometrium, and it affects implantation of fertilized zygote. So relatively, it has maybe low to medium efficacy. 97 to 99% still sounds pretty good to me. But again, the efficacy reduces as we get further out from unprotected sex, especially after that first 72 hours. And the other thing to note about this medication is its efficacy goes down dramatically if you're just overweight. So greater than 25, it'll go down. One of the nice things about this form of birth control, at least at Fort Belvoir, I think here too, this is one of those emergency contraception medications you can get over the counter without a script from the physician, whereas Ella, this one I've always needed to write a script for. So now we can talk a little bit more about my favorite form of birth control, a hormonal releasing IUD, like Mirena or Liletta or Skyla or Kylena or whatever you want to call it. Back in 2021, there was an article in the New England Journal of Medicine that looked at, it was basically a non-inferiority study evaluating hormone releasing IUDs and copper IUDs. And what they found was the pregnancy rate was about 1 in 317 for women who received the levonorgestrel IUD, 0 out of 321 who received the copper, essentially equivalent. So they decided that levonorgestrel IUD was non-inferior to the copper IUD for emergency contraception. Great. I was so excited when I heard about this. I presented it in a journal club. All right. So with that in mind, talking a little bit more about the levonorgestrel 52 milligram IUD, because they only looked at Mirena and Liletta. They didn't evaluate the Skyla. The window of treatment's also within 5 days of unprotected sex. It thickens cervical mucus, inhibits sperm passage, inhibits sperm survival, may also inhibit ovulation in some patients. One thing I noticed about the mechanism of the hormone-releasing IUD, I didn't see anything about implantation. I looked at UpToDate and Dynamed, and neither of them actually mentioned implantation, which was interesting to me. But it basically works just as well as the Paragard. It reduces your chance of pregnancy by 99%. It's not affected by BMI. To note, because it was all based off of this one study, the FDA has not yet approved this medication per se for emergency contraception use, but people still use it all the time. So I just want to go through this quick triage because I think it's interesting how we can talk about our patients when they are coming in requesting emergency contraception. And without belaboring this entire algorithm, I wanted to just kind of hit through the key points with regard to the patient calling in. You're asking if they have unprotected sex less than 5 days ago. If the answer is yes, then when was your last bleeding cycle? Was it within the past 30 days? Height and weight. So it does get into the BMI section and moving over to the IUD or the Ella. Remember, Ella doesn't work as well if the BMI is greater than 35. And then kind of working its way down from there. This is the Reproductive Health Access Project, and I have this resource available. I can, if you guys want it. This is from June 2022. Reproductive access. This is what I. No vice chair. We're not vice dean. We're not allowed to. No, you absolutely can ask questions. All right. Now let's talk a little bit about the post-Roe v. Wade era and how our military system has been affected in the post-Roe v. Wade era. Okay. So when it comes to administering abortions, the DoD's policy is that we will not perform abortions except in cases of rape, incest, or risk to mother, in which they describe the life of the mother would be endangered if the fetus were carried to term. That is it. What this policy did not do, and this is actually a memo coming from the Chief of Staff, Gilbert Cisneros, and this is June 28th. It essentially didn't change any of the practices that we do in military treatment. So all of these reasons to have an abortion, all these reasons to have an abortion are the same reasons that we're offering abortions at this time in the post-Roe v. Wade era. The policy did not change following the reversal. So very important. I've had a lot of patients that have come to me asking whether there were any major changes with regard to military treatment facilities and access to abortion after this came out. And I told them over and over again, there are no changes. We are still practicing the same way we have been. Okay. Now I want to get back to this kind of this bigger discussion point with regard to having the conversation with patients about emergency contraception. As I had listed all those different mechanisms of the emergency contraception, almost all of them except for the hormone-releasing IUD, one of the mechanisms listed was that it impairs implantation. So then if I have patients who are coming to me and they are believing that pregnancy starts as soon as sperm meets egg and we have a diploid zygote, they might consider these emergency contraception forms as a form of abortion. And so when it comes to our own thinking of this, we also need to decide when we consider pregnancy as starting, whether it's when that zygote has formed or when implantation has occurred. because we as providers need to know what we plan on doing with our patients before we ever talk to the patient. So if, you know, for me, I personally am comfortable with the idea of describing pregnancy as starting at implantation. So at that point, I would proceed with the discussion of emergency contraception with my patients and determining whether emergency contraception would be appropriate for them. And I am as transparent as I possibly can be when I talk to these patients. I want them to make the best informed decision as they can. Now, there are absolutely providers that will say, nope, pregnancy starts right at zygote formation, and because of that, I don't feel comfortable prescribing emergency contraception at this time. Okay, so what are the means for providing these patients health care? What access if you're not comfortable prescribing it? And then the last point I'd make on this is just ensuring, again, that the patient understands how the emergency contraception works prior to administering, so that you don't get a phone call 3 weeks later and they're really angry at you because they think they just aborted their pregnancy. So kind of a challenging topic. Just for sake of completion, since we are kind of in this tri-state, if you call it a tri-state area, I just, per Dr. Gosa's recommendation, I went ahead and found what abortion policies are available in DC, Maryland, and Virginia. In DC, it's legal throughout the entire pregnancy. In Maryland, it's legal up until fetal viability. I wasn't able to find whether they describe fetal viability as 23 or 24 weeks. So I put 23 to 24. And then for Virginia, they said it's legal through the end of the second trimester. So there's a ban after 26 weeks. So now kind of getting into a little more of, I don't want to say the fun, but I'm very military medicine oriented. I love hanging out with the Marines and flying and all that kind of crazy stuff. So I wanted to talk a little bit about what kinds of emergency contraception we could have used in those environments. So back when I deployed to Australia, I really sacrificed a lot for my country in that deployment. We actually only had access to combination oral contraceptives. We did not have Plan B. We didn't have ulipristal. We definitely didn't have access to IUDs. And so in that case, we did have combination oral contraception. And essentially, if that is the case, that's the only thing you have available to you. We essentially give a larger dose of the combined contraception and then a second dose about 12 hours later. Now it's got some fun pictures. One other resource that I kind of wanted to mention was, let's see, is which emergency contraception is right for me. And so this is something that our women's health providers often give out at Fort Belvoir Community Hospital for their patients so that they can essentially read through all three of the options. And when I say three of the options, they actually include Mirena and Liletta, so the hormone-releasing IUDs, in addition to the copper IUDs. That's all I got. So what questions you had? Thoughts? Discussion? When I actually asked this, talked about this previously, I was trying to engage the audience into telling me how would you go about having this conversation with your patients, what techniques would you use, and I got lots of really good responses. Sir? Uh-huh. Certainly. I think the purpose of this algorithm, as described when I spoke with all the midwives at Fort Belvoir who use it, this is actually given kind of to the nurse who's working on the nurse line when patients first ask about emergency contraception, so that they have this resource to go through it. As a provider, I don't think I'm using this quite so much because, as you mentioned, we're thinking about all the facets of the pregnancy. Including, whether there's any risk for STI or sexual assault or anything along those lines. I didn't look at another algorithm, though. Yeah, maybe that's a bad thing, yeah. This really gets into a really nice segue to my PIQI project at residency, which we're doing every week. We have a walk-in long-acting reversible contraception clinic called the PINT Clinic. Highly recommend it. It could be very useful in that situation. Yeah. I would in my clinic. That sounds good. Dr. Pierre? Yeah. Yeah, and I think that's a good point for us residents who are about to go to operational environments, that we have the opportunity in the pre-deployment setting to ask what our female soldiers might be using for birth control and whether they might actually be interested in a longer acting form of contraception. Dr. Garcia? That's a shame. I don't mean to cut the discussion off, but Dr. Garcia is up next, and so I'm going to give him the floor.
I let up. Alrighty, no problem. Good afternoon. I'm Dr. Garcia. I'm one of the third-year residents at Martin Army. I'll be talking about monkeypox and the obstetrical considerations for our learning objectives for today. The case. So Jane's a 26-year-old G1. She's at 32 and 0. She's in your clinic today for a routine OB appointment. She's heard about the monkeypox virus and is concerned about what this might mean for her pregnancy. And hopefully by the end of the presentation, you'll be able to answer these. Talk a little bit about the taxonomy of monkeypox virus. So it belongs to the Poxvirdae family, which is a group of double-stranded DNA viruses. Natural hosts for this family are invertebrates. So monkeys, rodents, dogs, cats are all fair game for transmitting this virus. Within this family, the genus that's important is the orthopox virus family genus. And the reason why that's important is because many of the commercial testing available at this time is orthopox PCR. based on that, there's a lot of viruses that are of clinical importance that are within this genus. At this time, you can presume that a patient is infected. Within this genus, there are some important viruses of clinical significance. There's the variola virus, which causes smallpox, which has been smallpox virus, the Vaccinia virus as well, and then of course the monkeypox virus. The virus is an important virus to consider because a lot of our vaccines are derived from that. There's also the Vaccinia virus immunoglobulin therapy. What it looks like in the world currently. So within the world, there have been close to 70,000 cases of monkeypox. Look at the top 3 locations where the most cases are. Number 2, number 3 are way below us at 6,000. Keep in mind that cases that are historically reported to have monkeypox are mainly the West African countries. Spread of this virus into other areas is normally found in some of these. For the United States, as of September 13th, there's been this area, we're doing pretty well. So a little 400 to 500 cases. Whatever's occurring in this area seems good because I'm from the South and I'm training in Georgia, and our numbers are drastically different. Comparing with the United States, it's pretty high. Some of the highest numbers are within the cases by age and gender. So the majority of cases are in patients that identify as male. Might be wondering, like, why is this important for OB? Majority of, 1% of the cases occur in patients that find that most of the cases that do occur are of reproductive potential. Could be a possibility. It could be on the different. How is it transmitted? Most notably, pox virus is transmitted through direct contact of the rash and lesions. However, if these lesions come in contact with inanimate objects like bedding, sheets, certain objects, they can be transmitted that way as well. Other forms of transmission, direct contact with infected animals. So vertebrate species are the natural reservoir for this virus. And so especially like pets at home, like cats and dogs, if you are presumed to have monkeypox or confirmed monkeypox, you might have to isolate from your pets because they could. Other forms of transmission include droplet contact with respiratory secretions, large droplet precautions that are obtained usually through like intimate contact or direct face-to-face contact. And then other forms, of course, of clinical importance is the vertical transmission. That includes semen, vaginal secretions, urine. Symptoms of monkeypox. So some patients can present with systemic symptoms like fevers, chills, fatigue, and headaches. Some patients do have like an antecedent respiratory, often nasal congestion and so on. Keep in mind that some of these symptoms do appear to look like flu, especially as we're approaching the flu season. And with flu-like symptoms, it could be monkeypox. Lymphadenopathy could also be present as well, and this is typically localized lymphadenopathy, depending on follows the drainage. Of course, most notably the characteristic rash. The incubation period for the virus is 21 days, so that's a long time, 3 weeks from exposure. Characteristic rash is present in 90% of cases. Frequency of other symptoms. If a patient presents with fever and systemic symptoms, usually within 1 to 3 days, a rash will. But some patients have, not all patients follow that clinical course. Evolution of the monkeypox rash. So the rash changes over time, and it makes broadens the differential certainly. The rash presents as this erythematous macules and papules with an erythematous base, and this rash can progress, enlarge, and form vesicles and pustules. Sometimes these vesicles and pustules can coalesce into larger lesions. Eventually, the pustules will rupture and unroof and will look ulcerative in appearance. Will scab over with time. Eventually, the scabs will fall off, and a fresh layer of skin will grow over the top of the lesion. And it's until that point is when the patient is no longer infectious. So this can take. Some lesions can also have an umbilicated appearance as well. Something to note, there are some lesions that are umbilicated. There's a lot that can look like monkeypox down there. So lesions with vesicles, group of vesicles with erythematous bases could potentially look like monkeypox or HSV. Ulcerative lesions in the genital region, whether painful or not, could potentially be monkeypox or something different. And then, of course, those pearly papules, umbilicated in appearance, present for a long period of time, could also look like monkeypox. Differential is pretty broad, but if a patient has some of the risk factors of monkeypox acquisition, then something to put on your differential. Up to 60% of patients that test positive or that have monkeypox could potentially have a co-infection with another type of. As they test positive for a certain STI doesn't necessarily. Risk factors in testing. So the testing recommendations for obstetric patients do not vary or do not differ from the general guidance about testing. So the main risk factors for monkeypox are recent travel to a country with monkeypox or with monkeypox that's endemic, whether or not a patient has had intimate or close contact with another individual that might have a rash similar in appearance to monkeypox or confirmed monkeypox, or if they've had CDC calls it close or intimate contact with someone in a social networking. Bars, clubs, online apps. Recommends that we test everyone that has this characteristic rash, and of course the risk factors with monkeypox. Have both of those, then we should offer. Type of testing depends on your area, so I would recommend calling your local and get in touch with the resources that are available. Also keep in mind that for the military population, those are vaccinated. Likelihood of a patient acquiring monkeypox is Now, what does monkeypox mean for pregnancy? Sort of the meat of the presentation. So monkeypox infection in pregnancy is associated with a lot of important things. Spontaneous pregnancy loss, stillbirth are possible. Preterm delivery is also possible, and monkeypox infection is also. Pregnant patients and those that are breastfeeding are considered immunocompromised and high risk for complications of monkeypox. POG and the CDC kind of released like their recommendations on what this means during pregnancy. At this time, for antepartum fetal surveillance, there isn't any sufficient data. Some OB providers might recommend fetal surveillance, but that recommendation is based on or extrapolated from evidence of other genital infections that patients might acquire. Timing of delivery doesn't change if you have suspected monkeypox, and so there is no indication for any preterm or early term delivery for these patients. There isn't any data about whether or not we should offer cesarean delivery. It's reasonable to offer a cesarean delivery if there is genital lesions that can't be covered and there's risk of exposure. Neonatal considerations, which I found to be pretty remarkable because our goal for obstetrical care is couplet care, and skin-to-skin contact is very important. But based on AAP recommendations and CDC, they do give some pretty remarkable recommendations for patients that have monkeypox. So neonates are at increased risk of severe infection, and they do recommend that neonates avoid direct skin contact with mothers up until the lesions have resolved. So keep in mind that that's 2 to 4 weeks after the lesion. Recommend that infants room in a separate room from mom, and they recommend that breastfeeding does not occur as mom is no longer infectious. It's unclear about whether or not monkeypox is present in the breast milk. That's why they make the recommendation to pump and dump. For neonates born vaginally, they recommend early bathing, so this even delaying vitamin K, Hep B, erythroid ointment in order to get baby bathed. Also isolate for 21. Or by a family member that has, that are not in their incubation. For vaccines in pregnancy, there are 2 available vaccines that are on the market. Technically, there's 3, but only 2 in the United States. And I thought that this was a very interesting recommendation because typically there is 1 live vaccine that's non-replicating. So therefore, patients are not infectious whenever they do receive it. So that's the Gynos vaccine. That is considered acceptable in patients that are breastfeeding or that are pregnant, as long as they meet the indications for pre-exposure prophylaxis or post-exposure prophylaxis. Typically, vaccine for post-exposure prophylaxis is best given within 4 days of the exposure. Oftentimes, patients might not be having any symptoms. Given within 4 days, the mom's or patient's risk of developing the rash is lower. But if you give it within 10 days, severity of symptoms is lower. It can be given up to 10 days. The other vaccine, the ACAM2000, is a live replicating vaccine. So this type of vaccine causes a lesion at the site of inoculation. Eventually, these lesions can also spread and be transmitted. And so that's why it's not recommended to be given during pregnancy. The patient receives this vaccine. They should not be in contact with patients that are at high risk, so immunocompromised patients, within the 4-week period of receiving. For treatment of monkeypox, so there are about 3 to 4 different treatments available for monkeypox/smallpox, and only one of them is available for those that are pregnant. That's the TPOXX medication. In animal studies, the TPOXX medication was not found to cause any fetal abnormalities, but there aren't any animal or any human studies available. Fair decision making and consultation with the CDC an option for patients. The other medications that are available aren't eligible for those that are pregnant because they are associated with fetal defects and miscarriage. And some patients that are pregnant may be candidates for the Vaccinia immunoglobulin. There isn't any direct data on this in pregnancy, but extrapolated the data from other immunoglobulin therapy offered or available in pregnancy suggests that it probably is a little safe. Back to Jane. So hopefully by the end of this presentation, you'll have some information to kind of give Jane questions that she might. can't really give any specific recommendations for obstetric patients. They kind of just base it all on the general risk factors. In the case reports where there was patients that are pregnant that were that had monkeypox, it didn't really talk about their risk factors either, but they did they occurred in endemic countries. That was their main risk factor, was just being. But there's one at Belvoir, huh? Wow.